normally is. Here's the way it goes. So a very high level player that the team really needs tears his ACL. They probably don't tell anybody. They probably don't release, oh, he had a knee sprain, because they want him to play the whole rest of the year. So he waits till the knee settles down, maybe a few weeks. They start playing him again. He starts playing again. John Elway, Super Bowl, goes to the Super Bowl without an ACL, functions. And then, they tell him, well, as soon as, off season hits, you're going to get your ACL reconstructed. And, he and maybe his agent or his wife or whomever say, well, you function pretty darn well without one. That's usually how it happens. And there are even a fair number of people out there who rupture their ACL and don't know it. That may be hard to believe, but they are out there and they function pretty darn well. There's a lot of people who, after a pro level career in sports, find out that they're ACL deficient or insufficient, and we're not aware of it. It is definitely an option. So let's talk about graft options. Those are options too. So currently, and still the case in the world, the hamstrings graft is the most popular, most used option. And that's the case in Canada, where they do almost solely hamstrings reconstructions, because it's a social healthcare system, and that's all they're pretty much allowed to do because it's the cheapest option. They're used a lot in Europe, whereas here in the United States, almost no one in the NFL or NBA would get a hamstrings graft. So there's a lot of controversy about how this is. So I worked for many years with a group of surgeons who covered an NFL franchise, but they also covered a lot of adolescent, high school level female and collegiate sports. They would put hamstrings grafts in female athletes and never consider a hamstrings graft in an NFL or an NBA player. You'd ask, why is that? Well, the NFL or NBA player needs the gold standard. They need that, what at that time, and a lot of people would argue still is the gold standard, which is patellar tendon, bone. Well, we'd say, well, if you're going to put that in if you have to have that in an NFL player, an NBA player, why are you going to put a hamstring graft in a high level collegiate Olympic level soccer player? Well, girls are smaller, their muscles aren't as large, they don't create as much force, maybe they don't need this bigger, which very often is a bigger, meatier graft, and it has bone on either end. So when you put it in the tibia and the femur, you have bone to bone interfaces on both sides. And when you put an interference screw into the two, you have a really solid construct. Whereas with the hamstring, you're using an interference screw on one side, and then you're using an endo button, or what's basically a molly, a suspensory fixation on the femur. There's more give to that. Mm-hmm. So I would argue this: hamstrings graft in somebody who already tends to be quadriceps dominant and taking 2 or 3 tendons out of the pes anterinus complex of say 5 total is really going to reduce, if you look at overall, their relative hamstring strength and hamstring muscle activation, which it does. That's clearly shown. And it takes at least 2 years to come back in the average person, if not longer, if ever. But also, say if you have a female soccer player who needs to internally rotate her tibia relative to their femur, as every soccer player has to do to dribble a ball and control the ball, taking that medial, 2 or 3 out of those 5 hamstrings out, tendons out, is a bad idea. They do it for cosmetic reasons, because a small scar on the medial side of your knee where the hamstring lies, in the medial posterior corner, is not as observable as this worm-shaped scar out of the front of your kneecap to your tibial tubercle. That's part of it. Anterior knee pain, women and girls. We've done these studies. Women and other female athletes have about a 25% risk of patellofemoral pain if they're playing sports like volleyball, soccer, and basketball. We showed that in those county studies that I told you about. We saw 25% incidence. So surgeons try to stay away from, that anterior compartment, taking that patellar tendon to utilize to reconstruct a ligament. That's also part of the problem.
Mm-hmm.
Now, a newer, although it's not necessarily new, it's just become more popular again, option is a quadriceps tendon. So above your patellar tendon and quadriceps. You can do that either all soft tissue, not take a bone plug off the patella, or you can take, if you want a bone plug on, say, the femoral side or the tibial side, you can take a bone plug from the patella. That gives an option, and the latest data is that option is just as good as a hamstring option or a patellar bone option. I like that option for multiple reasons. If you have a quadriceps dominant individual, maybe taking that tendon is going to balance things a little bit, and it's a big, strong, you can get as big a graft as you need. It's not going to be little, like in very many individuals, adolescent athletes, where those hamstrings can be very small. It can be as big as you want to make it. You only usually take about the central third, but you can take more. You can make it as large as you want. There's a lot of good options. The data is saying the outcomes on it are good. A lot of people will say that that's just because it hasn't been used in volume long enough. But the newest data out of Scandinavia, the Norwegians are starting to change practice based on this data. They used to do 90+% hamstrings, and now they're doing more and more bone to tendon bone, more and more quadriceps as well.
Mm-hmm.
There's kind of a high learning curve with the quadriceps, because you have 4 muscles, and they're all the heads of those muscles are all coming together at that quadriceps tendon. The fibers aren't all aligned, so a lot of surgeons don't like the feel of that when you cut it out, because it's not nice and linear like the fibers are of a patellar tendon or of a hamstring tendon. But more and more, it's becoming utilized, and most of the data is showing that its performance and outcomes are as good, and sometimes better than hamstrings or maybe even a bone tendon bone.
Mm-hmm.
So those are your options. The other option is allograft tissue from a cadaver. Allograft tissue from a cadaver is okay if you're a 40-plus-year-old pickleball player or tennis player, or you just want to go out horseback riding and be able to, put a valgus load on your knees to hold yourself to the belly of the horse. That's fine. Allograft's failure rates are multiples of what autografts. So the other ones we talked about, taking it from yourself, autografts, the hamstrings or the quadriceps or the bone tendon bone, they fail. Allografts, the cadaveric tissue, if you're young, physically active, going back to high level sport, they fail at multiples of the level of autografts. Those should not be used in young athletes. Although it still happens all the time, it's a bad idea. That the data clearly shows their failure rates are multiples of the autograft failure rates.
Mm-hmm. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.